So I had provided you with the slides of healthcare, health financing models, and I want to believe that you have them. And our major objective today is to look at various ways in which health can be financed in different contexts. As you may be aware, financial resources are very important in every community or in every healthcare system, and this healthcare financing is actually a core function of health systems that can have that can enable progress towards even universal healthcare coverage that we'll be going to look at after this topic, by improving effective service coverage and financial protection. As you may be aware, is that millions of people, especially in sub-Saharan Africa, do not have access to healthcare due to the costs, and many others receive poor quality of services even when they pay out of pocket. So a carefully designed and implemented healthcare financing policy can actually help to assess these issues. For example, contracting or payment arrangements can incentivize care coordination and even improved care quality of care. So we need sufficient and timely disbursement of funds to providers so that they can help ensure adequate staffing and medicines for treatments of patients in the different countries or in different nations or even states. It is against that background that we need to understand what are the financial or what are the healthcare financing models, what are the options, and which ones work best in our context. So, as introduction, the way I've just mentioned, the healthcare or healthcare needs of rich or poor countries are changing in response to lower fertility rates, longer life expectancies, and the shifting burden of illness towards chronic illnesses and injuries. If you've done epidemiology before, currently we have what we call epidemiological transitions. You realize that many developed countries or the Western have more of chronic illnesses and maybe injuries as compared to countries in the tropics or sub-Saharan countries where we bear both infectious and non-infectious or rather chronic diseases. And again, you will realize that most healthcare systems, especially in sub-Saharan Africa, is overburdened by the magnitude of these diseases. And initially, we had more infectious diseases killing people, but now the top killer diseases globally are actually chronic diseases. So we really need to understand how now we can finance healthcare based on those epidemiological transitions that are occurring globally. All countries are experiencing or varied degrees of demographic change, and high-income countries have low fertility and low mortality rates, while low-income countries, where many of us come from, are moving from high to low fertility rates with variations in mortality levels. So according to the United Nations population projections, the world population was projected to reach 7.5 billion by 2020 and 9 billion by 2050. It means as we progress, there are a lot of dynamics in health. Their needs are changing. What we need in our healthcare systems, needs are changing over and over. So we need to look at various ways in which we can finance our health. So mobilization of funds for healthcare is very important. Where we need healthcare, allocation of funds to the regions and population groups for specific types of healthcare is also a crucial need, and even mechanisms for paying for healthcare is also a very important need to our society. So we need to understand healthcare financing as a way of distinguishing between healthcare systems in different countries, help understand the roles of private and public sector in healthcare, and also understand the government policy in healthcare sector. We come from different governments here represented here. One of us from the US, some of us are from Kenya, and others are from South Sudan. So we need to understand and share various experiences that we get of financing, of healthcare financing that we get in our country, and which one do you think work better for us, and which one do you think may not work very well for us. And again, there are so many things that come into your mind. There are those that may seem to be working better or well, but then are they equitable? Do they favor everyone, or do they only favor those people who are well resourced, or do they favor those people who are under resourced? So there are so many ways in which you can look at various models of financing. So let's look at the various sources of finances, healthcare sources of financing. We have three major sources of healthcare financing. We have private expenditure, that which you can get from your pocket and pay for yourself. We have public expenditure. We call it pooling, that which the government or a nation has the responsibility on a mandate to take care of its people. And then we have external aid. In most cases in our countries, let's say, for example, in Kenya, we call it aid from non-governmental organizations. So public expenditure includes all expenditure on health serviced by central and local government funds spent by the state-owned parastatus enterprises, as well as government and social insurance contributors, where services are paid by the taxes that we pay. I'm talking about public expenditure. Or compulsory healthcare contributions, either by employees or insured persons, or both. These counts as public expenditure. For example, I don't know about Sudan, or I don't know about the US or a country. In Kenya, we have a public run healthcare financing we call the National Insurance, NHIF, National Hospital Insurance Fund. That it's based on compulsory contributions towards the pool, so that anyone who's sick can easily be funded or be provided with healthcare in one way or another. It could be having its challenges, but somehow I will say it is I can give it a 6 out of 10 or 60%. Yeah, I don't know about other countries. We also have voluntary payments by individuals or employees. These are private expenditure. For example, you work somewhere. Where I work, my employer normally pays for this. Then we have external sources, which refer to the external aid, which comes through bilateral aid, programs of international and non-governmental organization. In Kenya, we have things like US aid, we have UK aid, we have Care International, we have World Vision, we have a number of huge organizations, even Red Cross, that get their financing from our external sources, and they play a very crucial role in our healthcare systems. The ownership of the facilities used, whether by government, social insurance agencies, non-profit organizations, private companies, or individuals, are not very relevant when it comes to financing. So by and large, we have mechanisms of health finances, and we can categorize them in so many several ways. And those are the ones we are going to familiarize with. We have general revenue or earmarked taxes, that we pay taxes. And these taxes are used to take care of various aspects in the healthcare system. We also have social insurance contributions. You can contribute to an insurance, so whenever time you get sick, the insurance is able to pay for your medical upkeep or your medical expenses. We also have private insurance premiums. Social ones is when you take as a group Private ones is when you can take solely, maybe as a family. We also one that is works in some countries, community financing, where people of a certain community do pool financing. They contribute, let's say, monthly towards their healthcare financing system. And whenever any of them or some of them get sick, those finances can take care of them. This is actually very important because many a times these favors some community members who might not afford the huge expenses that may incur from healthcare when they get sick. We also have direct out-of-pocket payments. This is when you just walk to the hospital and you pay your bills upon treatment or before you receive treatment. Each method distributes the financial burdens and benefits differently within a community, and each method affects who will have access to healthcare. And of course, each of these mechanisms have some form of financial protection when it comes to issues to do with healthcare. Now, the general description of this, that what I've just mentioned, are that general revenue or earmarked taxes. This is the most traditional way of financing healthcare and finance a major portion of healthcare, especially in low-income countries. It provides social. So it's normally when we are taxed and the government takes care of the people. That's where we have different levels of hospitals in our communities, funding, amongst other things. And in Kenya, we have the county system that receives money from the national government, and then these counties, the counties play a crucial role in the distribution of these money with respect to different healthcare needs within their communities. Then we have social insurance. It's compulsory. This is where everyone is a eligible group must enroll and pay a specific premium or contribution to exchange for a set of benefits. For those ones who are in Kenya, social insurance is where now we have NHIF, where everyone who works is required by law to pay a specific contribution every month. And this is equitably done because the more you earn, the more you are likely to contribute. The lower you earn, the lower contribution is. I think the lowest in Kenya is around $5 in Kenya on a monthly contribution. And the highest, I think, should be around $20, I think, every month. So these social insurance premiums and benefits are distributed in the social compacts established through legislation, and premiums or benefits can be altered only through a formal political process. This is done largely by our policymakers within our country. Just like I mentioned before, it seems to be working, though having some few challenges here and there. We also have private insurance. This is when private contract is offered by the insurer to exchange a set of benefits for a payment or of a specified premium. So we have several insurance companies within the country which you contribute an yearly premium. In Kenya, you do an annual contribution. But I realize in some countries, especially in the Western or the developed world, they make it a little bit flexible that people can contribute on a monthly basis. So consumers voluntarily choose to purchase an insurance package that best matches their preference. And it's offered on individual and group basis. Under individual insurance, the premium is based on that individual's risk characteristics. So major concern is private insurance is biased adverse selection. So under group insurance, the premium is calculated on a group basis and risk is pooled across age, gender, and the health status. Meaning, one of the major disadvantages of private insurance, some of them may actually not give you the insurance based on pre-existing conditions. And they may also based on the age or even the gender. or even the health status. Because there's a time I was doing a study on road injury prevention, and I happened to have interacted with some insurance companies. And the insurance company told me their premiums were very expensive for males who are aged between 26 and 33. Reason being, studies have shown that those who are the ones who are more likely to cause road accidents as compared to the other age groups. So this insurance, private insurance, can have its own advantages and disadvantages. Another model of healthcare financing is community-based financing. This refers to schemes that are based on three principles: community cooperation, local self-reliance, and prepayment. Factors for success for community finances include technical strength and institutional capacity. This is where largely I can say a large group of people come together and take a group insurance. And these communities are normally of common understanding of some basic principles among them. Maybe are people with common interest, same age, same gender, common needs, amongst other things. And you realize many in a country like Kenya, women are the best people who uptake of community-based financing, where they do women groups and they actually insure themselves against the likely diseases they are likely to get based on their sex, or rather, I don't know their sex. I don't like using gender. Another form of payment is direct out of pocket. This is made by patients to private providers at the time the service is rendered, and user fee refer to fees the patient has to pay to public hospitals, clinics, and health posts, not to private sector providers. And one of the major problems, or one of the major strengths with this, people with who are well resourced can access any form of medical care within the shortest time possible, as compared to the other forms of financing that may require a lot of bureaucracies or a lot of approvals before you access this. And then it's been noted again, this is a general observation. It's been noted again, for example, in Kenya, it's actually cheaper sometimes for an individual to pay direct, especially cash payment or direct out of pocket, as compared to when they're using insurance, because maybe of delayed remission of insurance to the hospital. This is also happens to the national or social insurances, or the tax-based insurance. When you get an insurance from government, the cost is normally high for the government itself, because of course the delay it has in remitting to finances to the healthcare providers. That is another challenge that we have within our country. And in Kenya, I don't know, maybe you guys are going to share about your countries. We have actually a mixed approach of all this. The leading healthcare provider is actually the general revenue or earmarked taxes, which also is part, so social insurance is part of. We use NHIF, but then we also have private insurances doing very well within our country that are playing a very crucial role in healthcare systems. We also have community-based financing, not so huge, but it plays its crucial role in healthcare system. Direct out of pocket is humongous. It's quite very high. There are a number of people who pay only for their health when they are sick, and of course, this direct of pocket is normally influenced by a number of other socioeconomic reasons. So those are some of the ways in which we finance health. I don't know whether you're able to see the diagram that is on your screen. So generally, the functions of healthcare financing or the healthcare system is to revenue collection. It's funded by revenue from taxes, public charges, sales of natural resources, mandates, grants, loans, private insurance, and communities. So sometimes these resources can be pooled together for the common good, and sometimes they can be used privately by social insurance fund, private insurance organization, employees, and even individual households. All are actually meant to provide service in one way or another. They all have disadvantages and they all have disadvantages. So this figure basically describes the function involved in healthcare financing, which includes revenue collection, pooling resources, and purchasing goods and services. And these functions often involve complex interactions, just like you will see when you look at this diagram. And revenue collection is the way in which healthcare system raise money from households, businesses, and external sources. Pooling deals with the accumulation and management of revenue so that the members of the pool share collective health, thereby protecting individual pool members from large and predictable healthcare expenses. And pooling coupled with prepayments enables the establishment of insurance and the redistribution of healthcare spending between high and low income individuals, such as risk subsidies, and low and high income individuals. So pooling is normally very important because it can favor people within society who are disadvantaged in one way or another. Purchasing refers to the mechanism used to secure services from public and private providers. And in the functioning of a healthcare system, equity and efficiency are critical aspects for all financial functions. And there are three broad types of efficiency concerns: efficiency of revenue collection, allocation efficiency, and technical efficiency. Those are very important in every healthcare financing model. So health sector functions entail directly providing services, financing, regulating, and mandating service provision, and of course, providing information. The characteristic of many sub-Saharan Africa healthcare systems is that they have been characterized with a number of corrupt tendencies. In my country, we've had people stealing huge finances of funds meant for health or that have been acquired from the taxpayer level. So there is a risk, that's what I'm saying, in pooling, risk pooling mechanisms, because we have some types, like the National Insurance Service, that can be really be influenced either positively or negatively by politics. So is Social Security and voluntary private health insurance. All these no pure mechanism, usually a mix of two or more models work within every country. Purchasing, I've just talked about them. So all those forms of finances that we have talked about, be it insurance, be it taxpayer, be it the pooling, be it out of pocket, all of them have been synthesized and they fall under some specific healthcare models, and those are the ones we want to look at. So the healthcare model of every country is determined by the health financing globally. How is health financed in a country? So by understanding how health is financed in a country, you can be able to know in which model or which model a country is using. So for the national, we have number one is the national or state-funded healthcare system. A state-funded healthcare system has a number of characteristics. Funding comes from general revenues, there is universal coverage, and a public health delivery system. The strength of this is comprehensive coverage of the population and large scope for rising resources. The weaknesses with this national health care system or state funded is that there is sometimes unstable funding, especially when it's affected by the economic dynamics of a country. And sometimes there is disproportionate benefits for the rich and potential inefficiency in healthcare delivery. And it's also sensitive to political pressures. Like in our country, they keep changing the CEOs, the financial director. They don't survive for even 2-3 years. They keep changing. As a result, it really gets weakened. So national healthcare or state funding healthcare system. Many countries actually apply this. There is also health social insurance, social health insurance. We call it this Kamakian system. This is funding from employee and employer contributions, management through sickness funds, benefit package for all members. This one applies mostly in the working population of every country, where it is the obligation of your employer, be it a private or a public employer, to ensure that you have been facilitated for any healthcare eventuality at work. So many organizations actually put their people on health, be it state-based organizations or private-based organizations. The strength is that more resources are in the system and there's less dependence on budget negotiations. It is highly retributive dimension and cross subsidies in most cases. The weaknesses is that there is possible the exclusion of the poor. You can imagine these other people are working, and negative economic impact on payroll contributions. It also has complex and expensive to manage and escalating costs, and poor coverage of chronic diseases and preventive care are also there, because sometimes when it comes to Bismarck's system, that's the social health insurance, is that they might give you a limit. It's limited. You might be told you cannot spend more than 50,000 US dollars. Beyond that, you're on your own. So it's also limiting. It's preventive. It's limiting. So for chronic diseases, there is, and again, of course, sometimes again when you are reporting to work in a new employer, some employers want you to do some medical screening, and they may tell you from the word go that we are not able to cover certain conditions within our organization. So these can have negative effects. We also have voluntary or public health insurance. This is a characteristic, is voluntary. It plays as the primary or additional source of healthcare funding. It may be the main source of health coverage or duplicate health benefits or cover services not included. The strength is that it affords financial protection, enhances access to healthcare services, and increases service capacity and promotion innovation. So it helps finance healthcare services not covered publicly. So you'll find some people having, of course, the public financing, but at the same time, they take their own private insurances just in case they are not able to be covered from the other. The weaknesses is that can have financial barriers to access, differential access to healthcare, not service to quality also is a problem in this. We also have community-based health insurance. This is more of a community membership, and these community members play a crucial role in managing the system by themselves. And beneficiaries are excluded from other kinds of health coverage, and members share a set of social values. Voluntary affiliation and participation and solidarity is amongst them. The strength is that it's better access to healthcare for low-income people. It's because it favors the disadvantaged members of the society, and there is complete or fill the gaps of other healthcare financing schemes. Weaknesses, it's like it has limited protection for members, suitability is questionable, and limited benefits to the poorer part of the population has also been observed. So these healthcare models, healthcare systems, normally done in many countries that have socialized medicine. The government is dominant service player and provider. They fund themselves through, I'm comparing the two. They fund through taxes, and it has universal care. This model of a national health care system is largely practiced in the US for veterans only in most cases. For the Bismarck model, that's the social health insurance, private insurance is the dominant player. Fund is via employers. It needs additional mechanism for universal access. I also, from my literature, it also shows that in the US, this primary model is for citizens who are above 65 years of age. But in other countries like Kenya, it's for the general population. We also have national health insurance, which many countries use. The government is the dominant player. They provide hospitals, a mix of private and public. They are largely funded through taxes, and they also allow universal access. In the US, just for Lille, this model is for Medicare and medical aid. The out-of-pocket model, no organized system for payment and no pooling of risk. Access is limited. And the author that I was using today, tells me that in the US, this model is faced by a large number of the uninsured within their country. For us, let's say in Kenya, maybe or in even South Sudan, I can say almost 60% of our population is not insured. In most cases, this makes the taking care of the sick or patients in our communities become very expensive. In most cases, we are forming a lot of WhatsApp groups and to contribute for people who are sick in different hospitals, because there is no valid or there is no working insurance system that covers the majority of our country. So when somebody gets sick in our context, they are likely to pull even a lot of family resources down. And as we've been learning, you realize that sickness within a family or a community actually enhances poverty in very crude way. In Kenya, we say you only pray that you don't get sick, otherwise every resource will be taken away. So in conclusion, our healthcare systems are characterized by public or private mix and different methods of risk pooling, purchasing services, paying providers. They are not devoid of problems. Every type of financing has its own problems. And broadly, 3 alternative financing approaches are done, and no pure mechanism. We can say all of them have a strength and a weakness in some way. So I'm sure you interrogated these slides which I had sent to you. Now I think I'll want to listen to you so that you give me the experiences of your healthcare financing in your countries. But again, before that, I want to mention that the World Health Organization approach to healthcare financing on core functions is on 3 major aspects. One is revenue raising, that is the source of funds, including government budgets, compulsory or voluntary paid insurance schemes, direct out-of-pocket payments by users, and external aid. The World Health Organization also talks about the pooling of funds. This is the accumulation of prepaid funds on behalf of some of all or of part of the population. And lastly, it also talked about the purchasing of services. This is the payment of allocation of resources to health service providers. So in addition, all countries have policies on which services their population is entitled to, even if not explicitly stated by a number of government. By extension, those services are not covered, are usually paid by patients and sometimes they are called co-payments. So there are several concepts we need to understand on healthcare financing. And all I can say is that the concept of healthcare financing influences the health of a country at large. Yeah. So let me get your feedback, maybe your experiences on healthcare financing from your country, or what have you learned? Hilda, what have you learned?
Okay. Good evening.
Really?
So, for me, I had gone through the presentation, and I think what was not clear was the community financing. I think you
Yeah,
have explained.
yeah.
Maybe just a few examples
Mhm.
will help. I don't know if it's something that we are doing here,